and welcome. You're watching Medically Speaking, and I am Meenakshi Upreti. Today, we will pick up a topic which many in India are not aware of, which many are not talking about, but it's extremely pertinent. It affects not just MBBS students, it affects all of us. It affects those especially living in rural and remote areas. I am talking about a decision which NMC is likely to make. We're getting to know that NMC could make family adoption program a part of the MBBS training. What does this mean? What will be the ramifications of the same? What does it mean not just for MBBS students? What does it mean overall, really, for patient treatment, for reaching out in remote and rural areas? To discuss all of this and more, I have psychiatrists, physicians, doctors joining me from all over the world. I'm going to welcome all of you one by one. First of all, Dr. Shivani Malhotra joining us from the United States of America. Thank you, ma'am, for joining us. We also have Dr. Ravi Kohli. He's a senior psychiatrist from USA. Dr. Rakesh Garg, he's the honorary scientific director at IRCF. Also joining us is Dr. Lokesh Vidara, senior physician, joining us from USA. Very shortly, we'll also be joined by Dr. Ashish Khattar, senior physician. I'm going to start first of all with you, Dr. Malhotra. Help us understand, ma'am, how do you view this upcoming decision by the NMC? What really could it change, and will you call it revolutionary as far as MBBS training is concerned?
Yeah, I think it will be a great addition to the healthcare training in India. I did get trained in India, but I think we do still lack a good family medicine training because as a family physician is the one who can provide, a comprehensive care to the patient irrespective of their gender, age, or any issue. So I think this is going to help us to grow the family medicine in the rural area. We all know there's a lot of disparity in healthcare and kind of resources are limited in rural areas. So I think this program is going to help with that and increase the resources in rural area.
All right. And also help us understand, Dr. Garg, in India, when we speak of reaching out to rural population, it's remote. It's very difficult, of course, for people living far away from centers like AIIMS, elite institutes. And that is perhaps why we see huge queues, people literally sleeping on footpaths outside of AIIMS. How do you think one MBBS student adopting these 5 families, if it does actually happen, if it does see the light of the day, how could it change or revolutionize India's healthcare? And how is it going to help the rural population, sir, specifically?
Actually, I think this is an important question because if you understand the hierarchy of clinical management of patients, अगर हम देखें कि किस तरह का patient हमारे पास आता है, तो उसमें से 60 to 70% of patients will be for a disease which an MBBS student can manage, and this we need to understand. Yeah. All patients would not require a tertiary care help, and when they reach a tertiary care help, it's I think they waste a lot of time. So if we can provide something at the doorstep of a patient for a disease which he can manage, number one. Number two, if you can triage it, say out of 100, one patient would require a tertiary care. He will be a complicated case. And if we can provide somebody sitting at the footstep or the doorstep of a person who can triage those, treat 99 and send one patient to the tertiary care center, I think that will be absolutely a wonderful decision. And that is what we want. We want a hierarchy of patient management. We need some family physicians, we need some general physicians at the door level so that patient can get care. Because if you see, people are turning at AIIMS from UP, Bihar, they are spending 2 days in travel, they spend a lot of money, they lose their daily wages there. But on the other hand, if you can provide the same services to them and 9 patients can be treated off 10 from there, I think that's a very welcome decision. And that's the need for the day, actually. All patients need not to come to tertiary care center. There should be something primary care center. There should be something basic clinics nearest to the patient where they can get treated. And in case of any issue, they can be referred to higher center. And I think this is a need for the Indian population.
Right. And Dr. Lavi Kohli, sir, since we are speaking of the psychology of people, as a senior psychiatrist yourself, sir, help us understand, how do you think it's going to break that barrier? I completely agree with Dr. Garg. Not every patient needs to go to tertiary care. There has to be a very first-hand hand-holding, which more or less, unfortunately, has been missing when we speak of the rural healthcare system. How do you think, sir, it's going to help with the psyche of those perhaps who are reluctant to go to hospital? There can be varied reasons, be it their personal reluctance or economic reasons, which actually hinder from people from going to these centers, meeting doctors, or taking basic healthcare as well.
Yeah, good evening. Ravi Kohli here from Pittsburgh, Pennsylvania. Thank you for having us. The concept is very novel as well as revolutionary in the sense you're taking the care to the doorsteps instead of them coming all over from the rural areas to urban centers or town centers. So also, like you said, there is economic constraints and equity and access issues that also constrain a population to seek help at the right time, in the right place. So having the MBBS students for a 3-year period doing this on a continuous basis will not only educate the physicians very well, it will provide the required care at the right time, at the right place, with lower expenses and lesser resource utilization. So, and also, like you mentioned, I'm a psychiatrist. A lot of medical issues are related to behaviors, and including smoking or alcohol use, drug use, poor nutritional habits, lack of exercise, lack of sleep, and all those things. Many times, the outcomes we see at the end, when they result in diseases, it is too late to do anything. So if we address this the preventive and primary care process, educating them over long periods of time, change doesn't happen quickly. So over periods of time, having an established relationship between the doctor and patient will definitely allow us to
rightly said, this would be hand-holding, and it would of course be those MBBS students, being in direct touch with these families for a long period of time, and that can help in overcoming psychological barriers, whether lifestyle changes, etc. I mean, are big causes in rural India or not, that is debatable. Dr. Ashish Khattar is also with us. Before I come to Dr. Khattar, Dr. Adara, I remember last time when we were speaking, you spoke about a lot of efforts which you have undertaken, which your organization RP has also undertaken when it comes to helping out the rural population, especially in your home state of Andhra Pradesh. Help us understand really, sir, how do you view this measure? We'll of course have to wait and watch if it actually gets implemented, but what do you think of it?
Thank you so much for giving me this opportunity. I agree with currently this bring the family medicine on the debate on the front page. So that's really we already started, and it's coming from NMC. That's even excellent. So what we have said through the RP, we did adopt a village. We have done that for 30 years, and recently we did a conducted. I have seen the reports of high blood pressure in the rural villages, 45%, diabetes 30%, and we took the HPV vaccination for women, 9 to 11. 77,000 women die across India from cervical cancer, but the HPV vaccine rate is only 6%. 6%. It can be preventable. This education, the medical student goes and tells this information to the family, and then he will or she will go to the family and then implement it. So they own the issue. And also government has started very good medical colleges, went up to 90, I think 605, around 90,000. And there is family medicine department, post-graduation also needed. USA and other countries moved to the postgraduate level. So if they can able to, the DNB started 20 programs for each medical college, few of them just started this excellent move. And if they can do the 600 college, we'll have army of captains. See, in order to run these things, to success it, we need a captain to run it. Captain is a postgraduate family medicine physician who knows the pediatrics, OBGYN, and all those things. And so we are there to adopt few students, few colleges, along with the medical college and an experimental show to the colleges. And Dr. Shivani is a program director here also for the family medicine. She can explain more on that issue. So we are there. This is excellent opportunity for us to care for the poor and remote and rural areas. And current government taking the medical college all the way to district level. There are 700 some districts, and there are 6 lakhs of villages that we need. We don't need necessarily every village a doctor, but with the telemedicine like API, we did treated second wave. We did treated thousands of patients with the local family doctors. 99% of our patients never been to the hospital.
Right, and that's also, of course, a very revolutionary step, because in India also just about everyone, even in rural areas, has mobile phones on their hands. Access to WhatsApp also is quite accessible, even in the remotest area in India. Dr. Khattar, my next question to you. The center we know has already introduced a district residency program for all postgraduate students. Help us understand how these two programs are going to be different, and how is this specific program going to be better than what the MBBS students already have, and how it is actually going to help the rural population?
See, definitely, if you see the healthcare system in our country, many of our colleagues or us, once you have done your post-graduation and you have done your degrees, you move towards town and to higher cities to establish yourself, to have career fulfillments. In that regard, your rural population suffers, right? Then there are no doctors, then you have a number of quacks working out there. And actually, the healthcare facilities available to the rural population is underpowered. So by implementing such systems of working for more residency years in the rural population, more of internships and more of residency programs working out in there, you will have more people rotating every year in the rural population, which will help rural population to have more of the healthcare system and more of the availabilities there of the hospitals. So in that regard, if you see the government policies, whatever are turning up is definitely going to be beneficial for the rural population. As far as this residency program is concerned, you will have more specialized doctors reaching out to the rural population among all the specialties, and that is definitely going to be a game changer as far as the rural population healthcare system is concerned. And to some extent, it will give some orientation and eyesight to the doctors also, if they want to settle down in those areas, or to establish at least some sort of their facilities or extend their manpowers to this rural population over a period of time. And definitely that is actually going to help the concerns.
Right. There is no doubt about it that it is a game changer. This step is going to help the rural population in our country. But Dr. Garg, just to play the devil's advocate here, sir, many may today argue as well, and many may say that, all right, it's a great move that you have over 90,000 MBBS students who pass out everywhere, adopt a certain number of families, but what about our basic infrastructure? What about our healthcare? What about the spending which the government makes as far as our health budget is concerned? Perhaps many would say, why don't we fix that first? These are just stopgap solutions. What will you say to that argument, Dr. Garg?
I think there will be a lot of things which will require regular changes. So I think there cannot be a one single road to have the excellence in the healthcare delivered at the footstep of all the patients. So we have to follow the all norms. On one side, we are talking about the teaching and training. Second thing, we're trying to provide the healthcare facility at the doorstep. Third, we are strengthening our primary healthcare. Fourth, we also have to create something called a tertiary care center at various places so that those thriving and those patient care who require some advanced care can be taken care of. I think this is one of the steps. And yes, I absolutely agree that with regards to the if we talk of GDPs, we talk about the proportion of these spent on healthcare facilities. We talk about strengthening the healthcare facilities at the lowest bottom level, strengthening the infrastructure and the manpower at the primary health center. All those things has to be done in unison. And that is what is required. I think that's a very positive step that is being taken up. At the tertiary care center, yes, government is opening up many tertiary care centers in various states. Those will be the state of art. But simultaneously, I think this one, where we can provide the healthcare facility to each and every Indians, I think that's needed for the day. And this policy will strengthen those aspects. And we will be able to deliver the health packages to our population. And similarly, if you think of other schemes like, say, Ayushman Bharat and all those things, now when they are being added to it, probably this will emerge as one of the good concept that even when we talk about the financial constraint, If you talk of the other Western countries, yes, many of them are insured. But if you talk about the Indian population, majority of Indians spend out of their pocket for their medical services, for their medical benefit. And these type of services, when we are being provided by the government, I think they are not losing job. I see a lot of patients in my palliative care setting where they lose their job, their family members lose their job because they have to attend a tertiary care center for 3 to 4 days. Think of a person who is earning daily and eating daily. If he leaves a job for 3 days, come to the hospital for a treatment, his 3 day job is gone, he is not earning. And how this family suffers. If we can provide this type of services at the doorstep, probably we will be helping them. So I think this will be a multi-pronged strategy, and this is
a step in the right direction, and maybe one step at a time, as you rightly mentioned, sir. Be it Ayushman Bharat or other schemes, yes, a lot more can be done, but it has to start somewhere, and perhaps this addition in the course which NMC is thinking of is going to be a step in that direction, a very positive direction. But Dr. Malhotra, since Dr. Idara was just talking about family medicine, could you elaborate on that a little more? Help us understand, for an Indian audience, what exactly is family medicine, how it can help people in India, and especially considering we're speaking in the context of rural India, how can it help people in the rural setup?
Okay, just to correct, I'm the chair of the family medicine residency program, not a program director. They're different levels. But family medicine itself is a specialty in primary care. Okay, so the family adoption program, which NMC has initiated, I think is the first step, as you said, and it's a very good step because it'll, make people think the need for the rural health. Now, here also in US, there's the same challenge for the physicians going to the rural area. It's not always that here in US also the medical students, they always want to go to the rural area. So we do have some programs like the university I work with, University of Alabama, Birmingham. We recently initiated a program which is called Comprehensive Urban Underserved and Rural Experience Program. That's called CURE2 program. So what does this program do is it's designed in a way that we help to recruit the medical students from MS1, like the first year, second year, for them to come to family medicine so that they understand the need of the rural areas and they can go and practice in the rural area. So I think this program, the family adoption program, which NMC has initiated, at least it'll give a spark. It will give some kind of a thought process for Indian medical students and the government to think that, yes, the rural areas need a more specialized physician. So family medicine itself is a specialty. It's not like a GP. It's not like you start practicing after MBBS. As I think that MBBS training itself is not enough to take care of these, centers in the rural areas. Now, this adoption program will help them understand the needs of rural health, but it may not be able to give the expertise to these physicians to start treating these patients at all the levels. Okay. So I think there's a big need of the family medicine post-graduation program because you need additional maybe 2 years or a 3-year program, be it the DNB, be a post-graduation for 3 years, to understand the disease processes more in details, okay? So that you become an expert. Like if I train a resident here in a family medicine residency program, when my resident graduate from a family medicine program, they are able to work in the hospital as a hospitalist. They can take care of the patient in the ICU. They can take care of the patient in the outpatient clinic, be it treating diabetes or hypertension or high cholesterol, or even the OB patient or the pediatric patient. So they are now expert in treating all the patients of all ages, okay? So I think there's a need of an additional training, and I'm happy with this family adoption program because this will be the first step to at least assess that need. People will understand that, hey, we need to address the problems in the rural health. But yes, we do also need a little bit more training or a little bit more expert, because if we expect an MBBS student to take care of these rural areas and not send patients to tertiary care, they may not be equipped with the training that they need.
All right.
So I think
Okay, it's a step in the right direction. A lot more needs to be done. Yes, there is no doubt about that. But Dr. Khattar, help us understand this in an Indian context. End of the day, there are a large number of Indian MBBS students who pass out every year. 90,000, of course, if media reports are to be believed. There are Ayush doctors as well. I do agree with Dr. Malhotra. Yes, it would be beneficial if it's a longer training period. If a lot more, as I said earlier, can be done. But yes, a step in the right direction. Dr. Khattar, help us understand really the number, in terms of sheer numbers. What will this additional force mean for the rural population if each MBBS student adopts 5 families? What would it mean when we speak of a pan-India, accessibility to healthcare, especially pan-India rural areas, sir?
So please understand, this is a visionary step. It's a long-term thing which is going to happen. Now see, if every MBBS student adopts a one village or some 10 families or some 5 families, definitely over a period of time, your most of the population of the rural area is covered. So please see that by doing so, one, the training of that candidate improves. Two, as ma'am has already said regarding the DNB program of family medicine, again, a family medicine program student is enrolled in various departments over a span of 3 years of time, helping him to understand from medicine to surgery to gynae to pediatrics and to some extent of orthopedics, so that he can actually take care of the urgent emergencies and can handle day-to-day care concerns which happen in our general public. So as we have already discussed, that rural area is the most deprived area of any sort of medical facilities as far as the government hospitals are concerned, and definitely no corporates and no big turnovers go there and develop some facilities, whether it is financial issues. So in that context, if you see, whenever there is an MBBS student who is actually initially being forced, or if you can say a farsightedness, they are being posted in a rural area to help majority. So government do understand this thing. By doing so, both are going to get benefited. One, definitely our rural population is going to get benefited. Two, the student himself is going to get trained in a much better way, understanding the basics of the disease and the various basic sets of disease which do happen more in the rural area compared to an urban area.
Urban area, right?
So in both,
And I think Dr. Idara also wants to make a point. So adding postgraduate students is what you're perpetuating, Dr. Idara. Yes, please go ahead, make your point, sir.
Yes, because as Dr. Shivani, Dr. Malhotra suggested, the USA has this family medicine program almost 50 years. And if they want to do the all the examination, they don't, because our country is vast. If we need a captain here to run, the captain is a family medicine postgraduates. Then captain can use other resources like Anganwadi workers or healthcare workers or remote telemedicine. So that way it can be solution to depth of the, even the remote rural areas, we can have local people can give medicine sectors. Of course, MBBS, this is a very good initiation. And we thank Government of India, DNB started 20 diploma courses, 20 to 30 seats in Rajasthan and Tamil Nadu. If they can able to provide 605 medical colleges, that's I saw NMC site today, 20 or 30, that comes to the army of almost like 12 to 18,000 postgraduates overnight, over next 10 years. That give the army, that way, that's where we're going to. I read the article published by the NMC authors, and the reason the last 30, 40 years we're not able to get in because of this missing the captain. That's what we think. We will request government to look into that. Thank you.
All right. And my last question to you, Dr. Ravi Kohli, since we were discussing, earlier the psyche of the people, we've discussed all the work which RP has also done. Final word to you, sir. What would you like to say? We've been calling, of course, this highly likely move by the NMC a game changer. What does it mean really for the MBBS students? Because we've discussed all of it from the perspective of a rural population, sir.
It's a big ask on the MBBS students to take up this challenge. And I think we need to incentivize, maybe giving them some points for their entrance for post-graduation for doing this, and also provide the resources and supervision they need. Unless we cannot allow them to just do it freelancing. They need to be kind of aligned with some experienced physicians, like family practice physicians, family practice program directors or even internal medicine program, general medicine directors to guide them. Otherwise, if they don't get the resources and support and education, as well as some kind of incentivization, it may not work. But the concept is good. The resources have to be provided, both infrastructure as well as human resources for them to succeed. I think once they succeed, like Dr. Carter said, they may be motivated to stay back and provide the care. And they might adopt those villages for long term. And they might be the pioneers who will bring other people back to the system in rural areas. So it will be a convergence of good things can happen once we start the ball rolling. And like Dr. Garg said, we have excellent tertiary care, but we need to start at the primary care to prevent a lot of diseases and also to de-escalate the costs and burden on the family. Like Dr. Garg said, most of the out-of-the-pocket expenses are borne by the patients and families, unlike in many other countries. India has the highest rate of out-of-pocket expenditure for healthcare. And bankruptcies and loss of jobs, loss of family resources are very high due to a disease burden. So we're addressing many things by one stroke of a genius of act.
Well, absolutely. It is a game changer move. The practical aspects still need to be sorted out, but we do hope that it does get implemented for the MBBS students, some sort of incentivization. Whether it happens or not, we'll have to wait and watch. But considering the large number of MBBS students, almost 1 lakh who pass out everywhere, and I'm just speaking of allopathy, if each one adopts 5, you can imagine the multiplication effect. Of course, there were talks of how a class can adopt an entire village. Revolutionary ideas, whether they do get implemented on ground or not, we'll have to wait and watch, but certainly a step in the right direction. We really hope that primary healthcare, telehealthcare, as we've been discussing, reaches each and every person in our rural population. As of now, thank you all the doctors and the experts on the panel for shedding light on this extremely complex topic and helping us understand how it can help everyone, including and especially the rural population of our country. Thank you so much.
For more such videos, subscribe to the NewsX YouTube channel, hit the bell icon.